Hello, good afternoon everybody. I'm Dr. De Marco and thank you for inviting me to share my experience on the use of the Jfil. All we know that the indication on the use of the JJ stent in the urology, despite the indication of EAU guidelines, in more than 95% of urologists insert a JJ stent after an endoscopic procedure. Of course, all we know the problems depending on the presence of the JJ stent into the patients and the symptoms related to this device. Many of the symptoms related to the JJ depends on the movement of the kidney during the breathing and the irritating of the bladder during this contact. And this could be the solution. This is a Jfil. The Jfil is the typical shape with a proximal part of a tail of 2 centimeters, a shaft of 8 or 16 centimeters, and a tip of 3 centimeters. At the end of the tip, there are two proline strings of 22 or 14 centimeters. This is the core of this device. The distal part connected with the two proline strings that reach the bladder, free in the bladder. Into the Jfil kit, you can find, of course, a needle hydrophilic guide wires and the Jfil with the connectable eye pusher with an X-ray marker on the tip. This is a short video regarding the insertion of the Jfil into on the guide wire. This is the distal part with the two proline strings, and this is, of course, the insertion. It's very easy to insert using the X-ray images. Once you insert the Jfil on the guide wire, you can, of course, use the pusher with the X-ray tip, checking the correct position of the Jfil itself. And this is the X-ray control. You can see the guide wire, of course. You can see the Jfil movement on the Jfil on the guide wire. This is the pusher with the X-ray tip, and finally the X-ray image after the removal of the guide wire and the image of the inner part of the pusher. This is the final images. This is a short video showing the insertion in real time. You can see that, of course, the guide wire, the Jfil on the guide wire, and of course during the insertion there is a movement of C-arm just to check the correct position of the Jfil. This is the removal of the guide wire and the pusher. Always at the end of the procedure, I usually check the presence and the correct position of the strings into the bladder. This is a short video showing the image of the strings into the bladder, and this is the image of the ureter at the end of the procedure. This is one of my first insertions, so I decided to check the presence, of course, and the position of the distal part of the Jfil. And this is very important. This is a very important slide showing what's happening into the bladder of the patient during the movement of the breathing. So you can see the movement of the Jfil, of the strings of the Jfil toward the bladder without any contact of problems. And once we started to insert the Jfil, to use the Jfil, we have to learn how to follow up this patient. Of course, first of all, because the X-ray images of the proline strings, you can't see the proline strings. So how can we check the correct position of the proline? You can't use the CT scan again because you can see the image of the proline strings, but you can use, of course, the ultrasound scan. This is a bladder scan with showing the two proline strings. Again, another one. And again, we encountered another problem. This is an email I received from a patient that was worried about the presence of a broken double J, as indicated from the radiologist. But of course, we have to advise our radiologist that this is a correct Jfil implant and not a broken double J. How to remove the Jfil? Of course, we can use the different devices, the basket, the biopsy forceps, but I think that most useful device to remove the Jfil are the prelate capstro forceps with a long or short branch. The trick is turn the forceps after you catch the strings, close the tip and remove the Jfil. This is a very short video regarding this item. So we catch the prolate strings, we rotate, and we remove very carefully the Jfil. Again, another example. Catch the strings, turn the forceps, and remove carefully the device. And this is the Jfil out of the patients. So what do we expect from the use of the Jfil? Of course, we expect an appropriate drainage of the urinary tract, but we expect the reduction of the double J related symptoms. We discuss about the material of the body of the upper part. We discuss about the different lengths and sides of the body of the Jfil. We discuss about the use to knot or not to knot the prolene strings, to cut or not to cut the strings. We discussed about the size of the strings. 3-0 instead of 5-0 is a very small measure. And finally, the need of an X marks on the tip of the strings. After a very short experience, we decided that we don't need any change in the shape of the Jfil. This is my experience on about 274 endoscopic procedure. As you can see, I use the Jfil for after URS, after RIRS, after flexible, and in different other disorders. Very interesting is this short series regarding the use of the Jfil in the post URS for lower ureteral stones. Very often in this case we use the Jfil into impacted stones. So you have to consider that in these cases the site of the stone was not reached by the shaft of the Jfil, but just from the strings. So we evaluated this possibility to use to drain the ureter after the URS just using the prolene strings. And this is a very short video of the Jfil after the impacted stones. This is the Jfil, of course, into the ureter, and this is the site of the stones. And this is a very important item just to evaluate. These again are some more images. Very interesting I remove, of course, in these cases the Jfil, and I found in 34 out of 35 patients the absence of hydronephrosis. This probably means that the Jfil is very effective into the drainage of the ureter in impacted stones. I use in 275 out of 274 patients the 7 French for 16 centimeters Jfil with prolene 5-0 strings of 14 centimeters. I use 9 mini Jfil, but this is a very short experience. And I always check the strings position in the bladder in the post-operative endoscopic view. As a result, I remove 200 patients the Jfil with a follow-up of 30 days. I encountered no dislocation of the proximal part. I had 3 dislocations of the strings into the ureter, and I did this diagnosis using the bladder scan, and I can't find the prolene strings, so I decided to enter into the ureter and remove the Jfil without any problems. When patient with the mini Jfil had a self-expulsion. In just one patient, I have to remove the Jfil due to the fever. And So these are the results. We had the resolution of the nephrosis at first post-operative control in 194 out of 200% of the patients, so 97% of success. I also evaluated the ureteral symptom score, stent symptoms questionnaire, but the results are in evaluation. Only in 7 patients I had a severe back pain. Probably in this patient, I did a mistake because probably I positioned the proximal part of the Jfil too high, not in the pelvis but in the upper calyx. So I think that we demonstrated that there is the use of the Jfil. With the use of the Jfil, you can have an appropriate drainage of the urinary tract, a reduction of the double J related symptoms. Another issue is if the possibility to use the Jfil as a passive dilatation of the uterus by the strings into the two steps flexible ureteroscopy. This is a short video showing the passive ureteral dilatation of the ureter after 30 days. This was a patient in which I had to re-enter the ureter to do a second look after a flexible ureteroscopy. As you can see, you can evaluate the quality of the passive dilatation. This means that in some cases you can use the Jfil just to prepare the ureter. It's very important in that centers that they use to do a pre-stented positioning and then remove do the flexible after 30 days. This is another short video showing the elimination of small stones into the distal part. So that means that the Jfil has a real function into the dilatation of the ureter. Other indication could be in the use of the Jfil as auxiliary procedures in patients to treat by SWL, or we know that this procedure is not indicated from the EAU. Anyway, in some centers they still use the Jfil before they do the SWL. We could discuss about the use of the Jfil emergency. I don't think this is the real correct indication. So at the end, the answers we did when we started this presentation. Is the Jfil useful to solve dilatation? Of course, the answer was yes. Is it useful to prepare the way? Of course, yes. To drain the upper urinary tract after endourological procedures? Yes. And also in the lower ureteral impacted stones, you can use this device. So what we need is increasing the number of the Jfil implants and, of course, sharing the experience. Thank you very much.